Can you hear me? सुन्छ तिमीहरूले सुनेछ
सुनिरहेको सर
के छैन है मैले देख्छु स्लाइड देखेछ
छैन
हेलो
देखिएको छैन सर
देखेको छैन अब देखियो
यस सर देखियो
So today's topic class start गरे हुन्छ त
हुन्छ सर
Okay, today we'll be talking about anemia. So anemia is a condition in which there is a hemoglobin concentration which is 2 standard deviation below the mean hemoglobin concentration for a normal population of same gender, age, and race. It's as defined by WHO, right? 2 standard deviation below the mean hemoglobin concentration boundary, that's anemia, or it's also defined as quantitative or qualitative diminution of RBC or hemoglobin. It's called anemia, and which leads to decreased content of oxygen, right? Hemoglobin oxygen transfer garcha. So when there is anemia, there is diminution of RBC as well as hemoglobin, leading to decreased transfer of oxygen to tissues and leads to shortness of breathing, irritability, lethargy, or due to the decreased oxygen content as the hemoglobin level or the RBC content is decreased. Right? The following chart shows WHO threshold level to define anemia. So children between 6 months to 5 years, it's 11. So if less than 11, children 5 to 11 years, it's 11.5. So children 12 to 13 years, it's 12. Non-pregnant woman is 12. Pregnant is 11, and men are 13. So if the level is less than 11, then it's called anemia. So do you know what's the normal hemoglobin level of neonate? कसैले भने पनि हुन्छ normal hemoglobin level of neonate कति हो? What's the normal hemoglobin level?
Sir, 16 to 18 gram per year.
So in 16 to 18. So किन high hemoglobin हुन्छ न्युटेनमा न्युनेटमा कसैलाई थाहा छ? So the तिम्रो fetal circulation मा चाहिँ हैन तिम्रो right to left shunt भइरहेको हुन्छ है. So aorta को saturation is तिम्रो the partial pressure of oxygen in the aorta is decreased हैन. त्यो oxygen को level decrease भएकोले चाहिँ तिम्रो erythropoietin level is increased, and that's why hemoglobin synthesis is increased है. And so after birth तिम्रो PaO2, the arterial saturation of oxygen in the aorta is increased हैन. So the erythropoietin level is decreased हैन. त्यसले decrease गर्दाखेरि चाहिँ तिम्रो hemoglobin चाहिँ level decrease हुँदै जान्छ. So during neonatal life it's like 16 to 18, but after the तिम्रो neonate चाहिँ ठुलो हुँदै जान्छ त्यो चाहिँ तिम्रो hemoglobin level चाहिँ decrease हुँदै जान्छ है. So coming to history, so the anemia can be presented. So anemia is a condition, it's not a disease. The disease condition can be different in different age groups, and they can present in different ways. So age as presentation. So at birth, 2 to 3 months can present with pallor, lethargy, not gaining weight, irritability, poor feeding, dark urine, jaundice. So the cause might be blood loss, right? Maternal blood loss ले गर्दाखेरि पनि हुन्छ, or mother को hemoglobin is very low भने बच्चा. So during even in neonatal life, the hemoglobin might be very low, right? अर्को चाहिँ एन्टिपार्टम हेमोरेजले गर्दाखेरि हुन सक्छ है. अर्को चाहिँ इम्युन हेमोलाइटिक डिजिज such as RH or avian compatibility ले गर्दाखेरि पनि हेमोलाइटिक, that is immune है. इम्युन हेमोलाइटिक डिजिजहरु such as in RH or avian compatibility हुन सक्छ. Congenital infection such as torch infection है, यसमा नि anemia with thrombocytopenia हुन सक्छ. अर्को twin transfusion syndrome हुन सक्छ. अर्को चाहिँ congenital hemolytic anemia, so hereditary spherocytosis, glucose 6-phosphate dehydrogenase deficiency भयो भने तिम्रो मदरले के गरे सल्फर ड्रग्सहरु जस्तै कोट्रिमहरु खाछ भने बच्चाहरुमा चाहिँ हेमोलाइसिसको फिचर्सहरु आउन सक्छ, or if you give drugs to those infants. So in infants of 3 to 12 months, they might present with similar features such as can present with pallor, lethargy, not gaining weight, irritability, poor feeding, dark urine, jaundice, right? But the condition might differ. So 3 to 12 months physiological anemia, physiological and grows up, the erythropoietin level is decreased, त्यसले गर्दाखेरि अनि अर्को चाहिँ RBC को लाइफ चाहिँ in preterm babies it's only 60 days, and in term babies it's 90 days. So RBC पनि तिम्रो डिक्रिज भइरा हुन्छ है. So RBC को टर्नओभर चाहिँ अडल्ट को चाहिँ तिम्रो 120 days हुन्छ अनि तिम्रो टर्म बेबिज को 90 days हुन्छ, प्रिटर्म को चाहिँ only 60 days हुन्छ. So they are more prone, so preterms are more prone to anemia. So एउटा physiological anemia of infancy भन्छ हैन, त्यो चाहिँ तिम्रो erythropoietin level decrease हुन्छ as the PaO2 level is normal. अर्को चाहिँ hemoglobinopathy हैन. So at term हैन तिम्रो fetal hemoglobin चाहिँ 70% हुन्छ है, and fetal hemoglobin चाहिँ alpha 2 gamma 2 हुन्छ, and adult hemoglobin चाहिँ alpha 2 beta 2 हुन्छ. So when the fetal hemoglobin level is increased हैन at तिम्रो at term, तिम्रो hemoglobinopathiesहरु चाहिँ देखिन्न. So during 3 months to 12 months, so 6 months मा चाहिँ तिम्रो fetal hemoglobin चाहिँ decrease हुँदै जान्छ हैन. त्यसले गर्दाखेरि चाहिँ तिम्रो अरु hemoglobinopathiesहरु चाहिँ देख्न सकिन्छ. जस्तो थ्यालेसेमियाहरु चाहिँ तिम्रो बीटा 2 globin synthesis को deficiency भएको हुनाले तिम्रो यो थ्यालेसेमियाहरु चाहिँ only is seen only after 6 months है. 6 months हरु चाहिँ देखिन सकिन्छ. So that's why it's not seen at birth. Also the toddlers and children and adolescents acquired cause of anemia are more likely, such as iron deficiency anemia, vitamin B12 deficiency, or menstruating and pregnant teensमा पनि iron deficiency हुन्छ है। अर्को चाहिँ male or female मा चाहिँ male मा चाहिँ there are X-linked diseases such as G6PD deficiency and X-linked sideroblastic anemia are seen in case of males, whereas in females there might be excessive menstrual bleeding, which is an important cause of anemia. So onset and severity of symptoms. So common symptoms are lethargy as oxygen content is decreased. So they might have lethargy, tachycardia, pallor. Infants might be irritable and poor intake, poor food intake, or if there is anemia, other issues such as chronic diarrhea in case of celiac diseases. There might be chronic anemia as well. And numbness, tingling sensation in case of B12 deficiency. Also, history suggestive of hemolysis are changes in urine color or jaundice in case of hemolytic disorder, hemolytic episodes that occur in only male family members. And after taking any medication, there is deficiency, issue of bleeding, change in duration, history, duration and amount of bleeding, and past history, birth history, just age, duration of birth, hospitalization, history of jaundice, anemia in newborn period, history of anemia. So previous anemia inherited disorders and normal suggest acquired etiology. Travel to endemic areas of malaria, hepatitis, tuberculosis, issue of blood transfusion or intestinal resection or B12 deficiency or ileum B12 deficiency or family history, similar illness in the family, jaundice, gallstone, history of cholecystectomy, splenectomy, inherited hemolytic anemia, which suggests and breathing disorders, malignancy, and dietary history to intake. And kunta infant at discontinuation of formula, goat milk might lead to polychloride iron deficiency as well. Personal history can be delayed in case of iron deficiency anemia, and drug and toxin exposure, current and past medication or including homeopathic or herbal supplement indeed exposure or paint or and nitrates in the well water. So coming to physical exams, you can hear me?
Yes, sir.
Yes, sir.
So now coming to genophysical examination, palm, nail base, skin surface, anemia is 50 to 60%. So hemoglobin less than 7 grams per deciliter clinically, right? Paler. So the sensitivity is only 50 to 60%, and icterus, lymph node clubbing, edema, hydration status, vitals, temperature read, pulse, blood pressure, respiratory rate, anthropometry, or there are skin conditions which are associated with anemia. So there might be hyperpigmentation, such as or cafe olive spots in case of Fanconi anemia, jaundice. So pale color skin, hemolysis, condition ma. Petechia and purpura, autoimmune hemolytic anemia, with thrombocytopenia, hemolytic uremic syndrome, if there is blood mixed diarrhea, there is triad of microangiopathic hemolytic anemia, that you might see cystocytes with thrombocytopenia and renal failure. That is a triad of hemolytic uremic syndrome. And bone marrow aplasia, bone marrow infiltration, keratocytosis rash in case of parvovirus or Epstein-Barr virus, vitiligo in case of vitamin B12 deficiency, hemangioma, which can lead to microangiopathic hemolytic anemia. If there is huge big hemangioma, there might be thrombocytopenia as well as anemia. You can look for signs of nutrition deficiency in if there is a brittle hair or discoloration of hair. अर्को चाहिँ फेसमा चाहिँ फ्रन्टल बोसिङ or prominence of malar and maxillary bones हुन्छ हैन in case of hemolytic anemia such as thalassemia major or severe iron deficiency मा चाहिँ तिम्रो you can see on the picture this frontal bossing with prominence of malar and maxillary bones. In case of eyes, there might be microphthalmia in case of Fanconi anemia, which is associated with renal failure as well. Retinopathy can be seen in case of sickle cell anemia. Cataracts can be seen in galactosemia, also as well as with glucose 6-phosphate dehydrogenase deficiency. Edema of the eyes in case of renal failure. Glossitis in case of B12 deficiency. Angular stomatitis in case of iron deficiency anemia. In hands, there might be dry pharyngeal thumbs in case of rake cell aplasia, hypoplasia of tena eminence in case of Fanconi anemia, and spooning of nails in case of iron deficiency anemia. So during systemic examination, there might be normal, as well as if the patient is very severely anemic, the patient might have severe symptoms. There might be features of failure as well. So if there is symptoms of failure, so on chest examination, there might be basal crepes with added sound. On cardiovascular examination, there might be muffled heart sound or gallop, as to gallop or flow murmur. And you see, in case of abdominal examination, the anemia cause the hemolytic anemia, hemolysis hepatomegaly in case of hemolysis, there might be hepatosplenomegaly, such as in case of sickle cell anemia, thalassemia, or in case of infective disorders also splenomegaly or hepatomegaly such as malaria, Epstein-Barr virus infection, even in case of AIDS if there is hepatosplenomegaly, you can look for other myeloproliferative disorders such as leukemia, lymphoma, right? Or megaloblastic anemia, it is associated with central nervous system disorders as well. There might be peripheral neuropathy leading to ataxia, or weakness of limb, which can be seen in case of B12 deficiency. So these are the pictorial description of symptoms of anemia. So central fatigue, dizziness, fainting, low blood pressure in heart, and the patient might just come with the complaint of palpitation, rapid heart rate, chest pain, angina, heart attack, or spleen enlargement in case of myeloproliferative disorder or hemoglobinopathy. So there might be change in color in stool, muscular weakness, shortness of breathing, skin pale, coldness, or yellowing, eyes are yellowing if there is hemolytic anemia. So coming to investigation, so we can do blood grouping, complete blood count, total blood counts, and direct hemoglobin and platelets. So in case of microangiopathic hemolytic anemia, so in case of hemolytic uremic syndrome, thrombocytopenia with anemia with renal failure, you want to look for reticulocyte counts or RBC indices such as mean corpuscular volume, RDW, MCHC, or in the body, right? Also, the additional test that can be done is bleeding time, clotting time, prothrombin time, INR, APTT, iron profile, that is total iron binding capacity, serum iron, serum ferritin can be done. TB, TB, SGPT, ALP can be done to see the liver function test, and a direct Coombs test can be done to rule out any autoimmune hemolytic anemia. Osmotic fragility can be seen, and in case of hereditary spherocytosis, as you can see in the figure, or the G6PD enzyme could test or gonomylio in case of G6PD deficiency, Also, globin electrophoresis can be done to rule out any case of hemoglobinopathies. Also, bone marrow biopsy if you suspect a case of leukemia or leukemia, or myeloproliferative disorders, or if there is a cause is lead levels, you can look for lead poisoning. You can look for lead levels. Right? So now coming to the this is a flow chart showing to know the test to do in different diseases. Right? So first one has to do history and physical examination. Then look for a CPC, peripheral blood smear, and reticulocyte count. So if any patient is anemic, so you have to send at least if you see a patient is anemic, you should look for complete blood count, peripheral blood smear, and reticulocyte count. So if the patient is anemic, so if the retics are high, so if you should look whether the patient has the evidence of any blood loss. So if it's blood loss, then it's hemorrhage. But if there is no blood loss, you can do direct Coombs test. So if there is Coombs positive, then it's most probably due to ABO or RS incompatibility or autoimmune hemolytic anemia or SLE, right? Systemic lupus erythematosus. Or if you Coombs negative, then you have to look for hemoglobin electrophoresis, D6PD deficiency, osmotic fragility test in case of heterospherocytosis, and one can diagnose the disease. But if the reticulocyte count is low, then you should look for MCV level. So if the MCV level is high, then you should suspect macrocytic anemia. If the MCV is normal, then one should look for normocytic anemia. So and MCV is low, it's microcytic anemia. So macrocytic one should look for vitamin B12, folate, thyroid, or LFT, and consider bone marrow and sealing test. And other diseases in which MCV is high are diamond blackthorn anemia, Fanconi anemia, liver diseases. Of course, the MCV normals it's usually due to chronic diseases, right? Normocytic anemia. So iron studies, creatinine, thyroid, and bone marrow aspirate can be done. Or if there's pancytopenia, you should look for bone marrow, and you can diagnose leukemia, malignancy, and plastic anemia. If there is isolated anemia, only anemia, so it might be due to erythroblastopenia, due to viral infection, or anemia of chronic disease or renal disease. If there is MCV is low, the microcytic anemia, so you have to look for iron studies, hemoglobinopathies, and if the diagnosis is not met, then you can do bone marrow aspiration. So there's classification of anemia. So if it's 9.5 to 11, then it's usually asymptomatic and frequently skips detection. So there might be mildly anemic. So moderate means 8 to 8.9 and 9.5 may be present with other symptoms and warrants timely treatment. Whereas in severe, it's less than 8 grams per deciliter and warrant investigation from management. So this is the diagram showing causes of anemia. So there might be genetic hemoglobin disorders, such as in case of thalassemia, hemoglobin variants, phosphate dehydrogenase deficiency, or ovalocytosis. Also, nutrition, usually most common in pediatric age group. In adolescent, the cause of anemia is nutritional. Nutritionally, पहिला सोच्नु पर्यो के अब hepatosplenomegaly lymphadenopathy and you have to look for, if there is no fever, if the patient has fever, then you should go for, you should look for any malignancy of a high grade fever, chills and rigors, and you should look for malaria, or if there is hemolytic features like splenomegaly, jaundice, then you should look for hemoglobinopathies like thalassemia, sickle cell anemia. Also, nutrition deficiency such as iron deficiency, folic acid deficiency, B12 deficiency, vitamin A deficiency, protein energy malnutrition can lead to anemia. Also, infectious disorders such as soil transmitted elements, malaria, schistosomiasis, tuberculosis, AIDS, leishmaniasis, tropical sprue, malabsorption, and disorders of small intestine can lead to anemia. Microcytic. So this is the same picture showing the causes of anemia according to the MCV level as well as reticulocyte count. So if it's microcytic with low or inadequate reticulocyte count, then it's iron deficiency, thalassemia trait, chronic disease, inflammation or lead poisoning, sideroblastic anemia, copper deficiency, iron refractory iron deficiency anemia. High, if the reticulocytes are high, then it might be hemoglobin C and E or thalassemia syndromes, pyropoikilocytosis, or if the normocytic reticulocyte count is low, it's a chronic disease, RBC aplasia, malignancy, endocrinopathies, renal failure, acute bleeding, hypersplenism. Right? Also, if there is high reticulocyte in case of normocytic normochromic anemia, then it might be antibody-mediated hemolysis, hypersplenism, microangiopathic hemolytic anemia, membranopathies, enzymatopathies, hemoglobinopathies. Also, the macrocytic anemia, if it's low, reticulocyte count, folate, vitamin B12, acquired plastic anemia, diamond Blackman syndrome, Fanconi anemia, Pearson syndrome, drug-induced trisomy 21, drug-induced anemia, trisomy 21, hypothyroidism, active hemolysis with variants. So you have to classify whether it's microcytic, normal, and whether it's high, whether it's low, and you can come to a diagnosis. So now coming to the most common cause of iron deficiency anemia. That's anemia. That's iron deficiency anemia. So iron deficiency anemia remains the most common cause of nutritional deficiency in children in the world. So in US, it's 8 to 14% of children between 12 to 36 months are iron deficient, and 30% of the group progress to iron deficiency anemia. So in case of Nepal, 53% of the children is between 6 months to 59 months are anemic, according to NHDS 2016. So this is the diagram showing hemoglobin synthesis. So in mitochondria, glycine and succinyl-CoA with the help of ALA synthase, and with the help of pyridoxine, aminolevinic acid is formed, and ALA dehydratase with the help of that enzyme, which is inhibited by lead poisoning, right? And whereas ALA synthesis is deficient in case of sideroblastic anemia, which is aspirin, right? And forms porphobilinogen, and with the help of enzyme porphobilinogen deaminase, forms hydroxymethylabane, and with the help of uroporphyrinogen decarboxylase, corpoporphyrin is formed, and with the help of enzyme ferrochelatase, which is also inhibited by lead poisoning, heme is formed, right? So the rate limiting enzyme is ALA synthase. So if it's increased, if the ALA synthesis activity is increased, hemoglobin is decreased, whereas if there is increased hemoglobin production, ALA synthesis activity is decreased. So now coming to globin synthesis, the synthesis of globin chain is controlled by structural genes on chromosome 6 alpha, alpha zeta chromosome 16 or gamma epsilon and delta 11 right? So usually our hemoglobin Portland and usually it is a fetal hemoglobin and during birth usually fetal hemoglobin 70% adult hemoglobin and 6 months fetal hemoglobin adult hemoglobin level so fetal hemoglobin is very less, right? So hemoglobin synthesis, so 4 polypeptide globulin chains are arranged in pairs forming tetrameric molecule or globin 4% of hemoglobin. Each globin chain is attached to a heme forming hemoglobin. So you can see that there is tetrameric molecule that is attached to hemoglobin. So normally 1 gram of hemoglobin binds to 1.34 ml of oxygen. So oxygen binding capacity is 20.1 millioxygen per deciliter. When hemoglobin decreases, there is decrease in oxygen content of arterial blood, but there is no change in saturation. So saturation, hemoglobin decrease, saturation oxygen content is decreased. That's why the patient has symptoms. So oxygen delivery to tissues is cardiac output times the oxygen content of the blood. So daily dietary requirement is children they have to have 5 to 10 mg, a male 5 to 10 mg, females 15 to 20 mg. In case of pregnant, 20 to 30 mg. So only 10% of dietary iron is absorbed from the gut. So dietary requirement is greater than the body requirement. So that's why you should only 10% of the dietary iron is absorbed. So you should take more to prevent from iron deficiency anemia. So sources of iron are meat, liver, egg yolk, peas, beans, green leafy vegetables. So heme iron, which is ferrous form, is from animal products, whereas non-heme iron, that is ferric form, are mostly from the plant products. The absorption of iron is mainly occurs in duodenum and proximal jejunum. Increased absorption are present in presence of vitamin C, amino acids such as cysteine, lysine, histidine, and hydrochloric acid, and decreased absorption are present due to presence of phytates or tannic acid and calcium that is present in milk. So you shouldn't take iron supplementation while you take milk. Or there are forms of absorption. So ferrous form is absorbed, but it in ferric form. So all the ferric iron must be converted to ferrous form for absorption in gastrointestinal tract. So mechanism is absorption active transport is pinocytosis. So distribution of iron in body. So 65% is in form of hemoglobin. 30% is stored in case of reticular endothelial system, liver cell as ferritin. 4% in form of myoglobin in muscles. 1% in heme compounds that promote intercellular oxidation in form of cytochrome, catalase, and peroxidase. So there are forms of iron. The hemoglobin iron, the transferred iron that is known as transferrin, tissue iron that is also known as in form of ferritin or hemosiderin. So tissue iron hemosiderin bio or ferritin, plasma iron those are bound with transferrin or hemoglobin iron. So this is a diagram showing iron absorption and regulation. So dietary iron with the help of dietary iron that might be plant-based, that is ferritin or ferrous, is observed in the gut, jejunum or proximal part of duodenum absorbed and transferred to this to different cells with the help of transferrin, which is incorporated with other enzymes also, right? Causes of iron deficiency anemia. So increased physiological demand in case of prematurity, twins, growing children, adolescents, women during reproductive age, multiple gestation. Or pathological blood loss, in case of parasitic worms such as hookworm can suck about 0.03 to 0.2 ml of blood per day. Recurrent nosebleed or peptic ulcer or Meckel's diverticulum, polyp, hemangioma, inflammatory bowel disease, intravascular hemolysis, blood loss in case of menstrual losses, inadequate intake of diet in case of gastroenterostomy, celiac disease. Others are early cord clamping within 30 seconds and early that 1 minute once. So cow milk. So cow milk is a very low source of iron content, and there is blood loss from iron cow milk protein colytis and stuff, right? काउमाथि नभए बोबाइन मिल्कहरू पनि तिम्रो क्यान लिड टु मिल्क प्रोटिन कोलाइटिस. So again, I'm discuss the clinical manifestation of iron deficiency anemia are the most important sign visible after hemoglobin falls below 7 to 8 gram per deciliter. Look for pallor in saliva, microscopiation. So finger becomes, it's called as platinikia, even spoon shaped. It's called cholionikia in long standing and causes atrophy of tongue papilla resulting in bald tongue. Right? Papilla open atrophy and the spooning of the nails long standing flat or so platinikia, cholionikia, and atrophy of tongue papilla. So hemoglobin, if the hemoglobin level is 6 to 10, compensated mechanism, so increased levels of 2,3 diphosphoglycerate and shift of oxygen distribution curve may be so effective that only few symptoms like cold intolerance, fatigue, and exercise dyspnea is noted if the hemoglobin level is 6 to 10. But if the hemoglobin level is less than 5 gram per deciliter, the patient has systemic symptoms such as irritability, poor feeding, lethargy, systolic flow murmurs can be heard. If hemoglobin continues to fall, there might be tachycardia, high cardiac output failure. So there might be pedal edema, dyspnea, increased jugular venous pulse, congestive hepatomegaly, and basal cramps. Also, the non-hematological effects matter. Iron deficiency are associated with impaired irreversible neurocognitive function. There might be risks of seizure, attention deficit hyperactive disorder. There might be breath holding spells in children, stroke, and exacerbation of restless leg syndrome in adults. So there might be pica or pagophagia, in which there is desire to ingest non-nutritive substance like mud and ice. So there might be hematological and non-hematological effect of iron deficiency anemia. So non-hematological effects we have discussed, which might be irreversible neurocognitive function, risks of seizure, ADHD, breath holding spells, stroke, exacerbation of restless leg syndrome, pica, and pagophagia. So when there is a decrease in hemoglobin, so in first the tissue stores are decreased. So there is the hemosiderin level decreases and serum ferritin level decreases. And next, the serum iron level decreases. The serum transferrin, serum iron binding capacity increases. The percent saturation, the transferrin saturation falls below the normal. And later, the patient presents with microcytic hyperchromic poikilocytosis and increased RBC distribution width. So the response to low hemoglobin is first the hemosiderin level and the ferritin level, the storage form is decreased. The iron level is decreased, and the saturation and total iron binding capacity is increased. The transferrin saturation is decreased, and later microcytic hyperchromic anemia also. So other differentials that you should keep if you suspect the case of iron deficiency anemia. So because iron deficiency anemia can be thalassemia may present as a case of iron deficiency